Hi there, and welcome to the show. My name is John Ivison. I'm your host, and I'm joined this week to talk about the healthcare summit between the premiers and the Prime Minister by my National Post Ottawa bureau colleague Ryan Tumilty, and by Michael Rachlis, a public health physician who's also an adjunct professor at the University of Toronto's Dalla Lana School of Public Health. Welcome to both of you.
Hello.
So I'll come to each of you in turn. Ryan, you on the politics, Michael, you on the health implications. Ryan, politically, I said in my column that the premiers didn't get what they expected, but they probably never expected they would. The deal amounts to $46.2 billion of new money over 10 years. That's in addition to the $150 billion that had already been expected to come into the system. Will they take it? And does it heal any divisions in the Federation?
I think ultimately, we'll wait to see, of course, but I think ultimately they will take it because healthcare is such an important issue for every jurisdiction right now. They didn't get everything they wanted, but like you said, they wanted $28 billion a year immediately. That's a larger sum of money than we spend on the Department of National Defense. It's a huge commitment for the government with what they were asking for. So I think they'll take this as a win. I think they'll take it as progress. And, it's not a lot of money in Canadian healthcare terms, but it's still $46 billion.
Sure. Michael, is it material? And do you think it was an error not to insist on requiring the provinces to make reforms?
There's a whole bunch of things that the federal government might have asked in return for money, including reforms, including the data that looks like they might get, dealing with the Canada Health Act issues, which didn't seem to even come up. So I think that there's was a lot of pressure on the federal government, and they came up with what most people thought was at the low end of what they would give. Will this stabilize the system? I think it will to a certain extent, and the premiers have flagged this. However, I think that we also, it's been flagged by Mr. Ford for sure, this is a down payment. It's not a final offer. So I know that just like in the early 2000s, it looks like the provinces are going to keep coming at the federal government until they get a bigger number.
Ryan, you write about healthcare fairly regularly. It's not often a ringing endorsement of a system that's functioning well. The story seems to be that we have world-class care if you can access it. There is disquiet among the public. There was an Ipsos poll that said a large majority want to see drastic changes. And even for the first time in my memory, a majority saying they're prepared to look at private delivery of publicly funded healthcare. Do you think we're going to see major changes in the way that healthcare is delivered and managed?
I don't think so, because that's not built and structured into the deal. This is ultimately a deal about providing more money to the existing system, not changing the system. Now, there's sort of two caveats there, though. One, there's almost what's not in the deal, and the Liberals did not at all insist that this money be used for public delivery. Yes, public payment. You're still going to pay for everything in the healthcare system with your health card, but private companies are going to be able to do some of the surgeries and things like that, which is what we started to see in Ontario this year. Ontario Premier Doug Ford opened that door, and there was no objection from the government here in Ottawa, which was sort of unusual. So I don't think we'll see some change there now that they're saying that they're okay with that. They're also insisting upon, as part of this deal, for a big contribution of data, a big understanding of how the health system works, and an ability to see how the health system works province to province. So to compare wait times, say, for surgeries, province to province, to compare access to family medicine, province to province, in real concrete ways. And I think potentially 5 years from now, that might lead to bigger change. The Prime Minister said, on business maxim, which is unusual for him, he said, what gets measured gets done. And I think that's what they are doing with this, to potentially make changes down the line.
Michael, you've been critical of private delivery, and I can see that, clearly for-profit healthcare wants a profit. And I can also see the prospect that nurses, for example, could be poached by companies at the expense of the public system. But wouldn't it also increase the capacity, for example, for elective surgeries and reduce pressures elsewhere in the system?
We need to do more surgeries, some elective surgeries, especially like joint replacements. We're not doing enough to meet the demand, and that's why this wait list is there and it's growing. The best way to do this is to use so-called focused factories, not an operating room that's used for heart surgery and neurosurgery and this and that, but just one that's focused on cataracts, let's say. So that all makes sense. However, what was not part of the conversation really is that we have very large not-for-profit ambulatory surgery clinics, the largest one in North America, the Queensway Surgery Center in part of the Trillium Health Service in Mississauga and Etobicoke. It's the largest one in North America. So that using so-called focus factories to do this surgery, that efficiency and sort of like going to Disneyland, right? And your waits are wonderful as you go through the system. That's not new. And again, we have some large public clinics. What was a little different was that Mr. Ford sort of announced in a public facility, the Kensington Health Center, which has long-term care and does more cataracts than New Brunswick does every year, et cetera. It's a not-for-profit facility, and yet he was talking about mainly using private delivery. The Canada Health Act does not restrict the provinces from using for-profit delivery as long as the patients don't pay more. And that's what Mr. Ford said. That's what Mr. Trudeau said. Unfortunately, what they're not saying is that investigations by a number of groups, including the Globe and Mail, sorry to mention, have found that these for-profit facilities are often upselling services that aren't part of Medicare, and they're also levying charges which appear to be part of the insured service. One piece of the Globe investigation a few years ago showed a woman was paid several $1,000s to see an orthopedic surgeon months earlier than she would have seen him. And once she saw him, then she could get on the list for the public hospital to get her new joint. So that we've got a fiction going on where everything is covered by the Canada Health Act. It's all kosher, but nobody's actually checking the Canada Health Act out. So that's an issue. And of course, the other issue is there are these public facilities that are doing surgery already, and we could just simply use more of them. A number of studies, including in Canada, have shown that they tend to be cheaper than the for-profit outfits, which means that for $1 million, you get more surgeries in a not-for-profit facility than a for-profit facility. But it's not against the Canada Health Act for it to be done like that.
Right. And I mean, I think somewhere around 28% of all healthcare in Canada at the moment is privately delivered. So as you say, it's not new. Ryan, on the politics of it, we've seen polls recently that suggested even the Conservatives are ahead of the Liberals when it comes to the public's view on healthcare, which is the first time in my 20-plus year memory. What do you think? Is this a win for the Liberals?
Obviously, with the caveat of as long as the premiers sign on and we move on from this, I think the answer is yes. Because I think Canadians, to start with, generally blame their provincial governments when their healthcare isn't up to snuff, because they are constitutionally responsible. I think it's one of the few areas that people really understand that. But we've seen for about, like you say, about 6 months, I would say, we've seen Liberal support start to slip. And the two big issues have been cost of living and healthcare. And I think they can say, concurrently with this, you've done something on healthcare. It's $46 billion. Like I said, it's not what the premiers have been looking for, but to most people, that's a significant investment. And I think it will be able to say we are making real progress.
Michael, my colleague Sharon Kirky quoted you in a very good piece recently. And there was another quote that really stuck with me, which was an emergency department doctor saying that simplistic attempts to fix a complex system often have unintended consequences. So clearly there's no easy fix. It's a complex system. But what, in your opinion, would be the smartest things the provinces could do right now?
Yeah, I think the provinces could do a lot of things, but one of the things they really need to do, and particularly in Ontario, is stabilize their healthcare workforce. Every day, we've got thousands of nurses who don't show up for their shifts because they're so unhappy at their jobs and unhappy at the provincial government too. So I think that that's crucial. There's new money in this. Mr. Ford underspent his health budget by almost $2 billion last year. So there's money available. And I think that stabilizing the workforce by some grand gesture, for example, saying $5,000 for every nurse and nurse's aide, et cetera, in the health system. And that's just because we feel badly about the way we've treated you. Then we're going to throw away this 1% cap on your annual raises, and we're going to negotiate in true good faith. I think that would be the first thing that certainly Ontario needs to do. Several other provinces need to do. And then the second thing is we need to do a much better job at what Tommy Douglas called the second stage of Medicare. He said the first stage would be public payment for the old system focused on treating illness. We haven't completed that because we don't have pharmacare, Dentacare, a lot of other things. And he said the second stage would be a new system designed to keep people healthy. So this is everything from we're not treating thousands of heart attacks and lung cancers this year because people aren't smoking at the same rates as they were 20 years ago. And it also means today a study came out showing that congestive heart failure patients leaving Canadian hospitals are not likely to get simply the drugs they need to prevent them from being readmitted. Congestive heart failure is the number one reason why Canadians are hospitalized. We need to do a way better job of making sure that the patients being discharged today won't come back to hospital tomorrow. So there's other things I'd recommend, but stabilizing the workforce, so because then you get thousands of nurses coming to work who aren't going to work, and then doing a better job at patients going home today so they don't come back. About 30% of congestive heart failure patients are back in hospital within a month or two.
Well, I mean, it struck me as well. You've talked about other efficiencies, and one thing that I noticed recently, I mean, you need to see a doctor to get a prescription refilled, which doesn't seem to make sense. It would seem that we could use registered nurses and pharmacists in particular a lot more efficiently.
Yes, and that's been happening, but it's really slow in Canada, much slower than in the United States. There's, I think, almost 10 times as many nurse practitioners per capita in the U.S. as in Canada. So we have not brought in those other providers who could provide those services, and we've done a terrible job at putting teams together. So sometimes there's been initiatives where family doctors are told, well, refer your patients to an addiction counselor 30 kilometers away who your patients have never met and have no trust in. That doesn't work. You need small teams around family doctors to make them more efficient. You're absolutely right. They don't need to see every patient. Best evidence is that probably 50% of the patients they see could be treated better or as well by some other provider.
Right. Just a last question to each of you. Ryan, on the fiscal front, we've got a budget coming up. This offer does not in and of itself seem to have burst the bank as far as making our finances unsustainable. But there was a study this week from University of Calgary economist Trevor Tome, who said outside of transfers to provinces and to people, the government needs to reduce all other spending by 17% over the next 5 years to hit its own targets. That does not suggest that we're going to see a budget brimming with goodies.
No, I would expect a really restrained budget going forward. I mean, the finance minister has already been sort of telegraphing those things, that she's going to be saying no to most things. I think you'll see some money for green incentives to match what happened in the US. And I think you'll see this healthcare money in that budget. I think the reason this was so constrained was the government's financial situation. The finance minister herself has said, unlike before the pandemic, the federal government is in a pretty significant deficit position and provinces are running surpluses. So they weren't that eager to be that generous.
Right. Michael, last word to you. You wrote on the 2004 agreement. Very few of us were around who covered it and remember it, I think. But you essentially said it was a missed opportunity, that the money was untargeted and it removed the leverage from the provinces. And essentially, once they got home with their cash, they were, in your words, mugged by doctors and nurses who were looking for large salary increases. Do you feel any more optimistic this time around?
I feel a little bit more optimistic because I think it's clear where we need to go. I think that it is pretty clear we need to get the elective surgery like cataracts out of a hospital setting, put them in, I would say, for-profit focus factory kinds of things. It's very clear we need stronger primary health care. People don't have family doctors and then they can't get into the system, which is quite wonderful once you actually get in. So I think that's a bit clearer. However, without a real plan at the provincial levels, like the province are going to have bilateral negotiations with the federal government, it's not like they have a strategic plan. They can say the federal money fits right in here. And if they don't, then what's going to happen is that even though nursing leaders and physician leaders, I really think, want to change the system, their members won't let them just willy-nilly agree to things that isn't being asked for. And their members want more money because they're facing inflationary pressures. So I think the calculus of it all is that without that good plan, then doctors, nurses, and others will pressure for more money and for more or less what they're doing now. I hope it doesn't happen that way. Just like Medicare itself, I think Canadians will have to be vigilant to make sure that this new money is used properly.
Here, well, we're out of time. Thank you very much for your time and for yours, Ryan. We'll see you next week.